71-year-old lady, plasmacytoma. Um, this is seen by the onco and then referred to an orthopedic surgeon. And so pain was getting worse, so they worked it out. She was sleepless. This is a few years back, 2.5 years back. So the first ARS will come up. How would you manage them? This is a single plasmacytoma, no spread, no metastasis, 71-year-old lady, no comorbidities. What would be a standard? So you've been referred this patient from the oncologist, and how would you handle this? There is an infraction on the lateral cortex, so radiation, chemo, graft, and unblock. So most of these guys are going to be unblock and hemiarthroplasty. That's interesting, very interesting. That takes this ground. Oh, this is going to go for a long time. So surgeon was also in the same group as the D, and he did this and excited. Apparently his contention to the patient was that this is fatal, not going to last the length. So he told his daughter, let's do this, give her pain relief, and went ahead with this. And this is 2.5 years back. And this is a standard long stem, removed en masse, subscap, rotator cuff, proximal humerus, but above the pec major level. Panel, would you do the same, Ramakant?
There is nothing left in there.
No, but the point is she needs to be pain-free. So you're dealing with a cancer patient. We're not looking at function.
No, plasmacytoma, if my memory serves me right, is a sensitive tumor.
It
so
is.
Other modalities should have been tried before going out to this kind of excision.
I would be in the same room as Pankaj, and I would have said that the tumor that we've taught in our undergrad days and postgrad days was that it melts. But once a fracture happens, then it's a problem, right?
Yeah, then maybe a prophylactic nailing.
Nailing would have been the choice.
Was my first logic that this should have been done, but this was a bit radical. Surgeon's contention was that it was fatal and you want to do this, and she was okay. She had no function. This is 2 years later.
I think the problem is
not that problem.
Yeah.
I think the problem is repair, rotator cuff repair to the proximal.
Well, he did tie whatever tissues were there to the prosthesis, but that doesn't work. I went to the notes extensively, but it's just a soft tissue repair. And this is like a disaster. Look at the lateral down here, and you can see what's happening here. It's all popped out. There's nothing to support. And she survived beyond the year. She's 2.5 years now and sent to us. And she's miserable. So your second ARS starts now. How would you do this? It's a nice graphic 3D print of her prosthesis. So just looking from the skin, you can tell which prosthesis it is. Leave alone, reverse, lower trapezius and SCR. So there are surgeons who have done an SCR for a total shoulder replacement when the cuff tore, and then an excision arthroplasty. So we got almost 40% heading towards an excision arthroplasty, and I was thinking on those lines to start with. And then there were, who's the next best? 2, reverse shoulder replacement. There's a problem, right? Reverse shoulder replacement. There is no stability there. There is a deltoid. The antedeltoid is completely flat. The posterior and lateral deltoid is firing, although thin, still functioning. Basin sir, koi gunjaish yahan?
No, I think excisional arthroplasty, and you may consider, if she has a good prognosis, filling up the gap.
And stability
Just put a bone graft.
in that gap, but no soft tissue, so chances of dislocation high. We can make her worse, right? My thing was, is it possible to make her worse, or should we just no touch technique?
No, I think it needs an excisional arthroplasty, that I would say. And fill up that gap with a graft if she has a reasonable prognosis. Filling it up with a graft should be done. That's all.
Maybe
Ashish, how easy is it to arthrodese the shoulder? As Basin sir is suggesting, fill it with a
I don't think so. It will be an easy to arthrodese. Just fill that graft to provide some sturt in between.
And arthrodesis post-reverse itself is difficult.
No, it's
This
difficult.
one, he's just ensured that there is no contact between the distal and the proximal. So arthrodesis was out. And with her age and the fact that you must also understand in the background that she has received steroids, she has received osteoporosis medication, she received those injections, zoledronic acid, once a month, which we give once a year. So I spoke to the senior most oncologist, ki, Are, one of your colleagues has prescribed once a month. We said that is protocol for
It is done, yeah.
multiple myeloma, especially because of the hypercalcemia and things. So, but they don't care about what happens to the bone. So that's going to be very fragile bone to deal with.
What is the survival of this patient? The oncologist's opinion? Is it, I think it's a localized disease, plasmacytoma. So
It is, plasmacytoma is 10, 11 years. He went on a complete different take when he said that it's a 1-year disease, and that's why he went in and did this. Such.
And
No?
the deltoid insertion is gone. If you look at the X-ray.
Deltoid insertion is there, pec major insertion is there. We confirmed that on ultrasound and the subsequent MRI images I'll share with you. The anterior deltoid is all flushed out, it's completely wasted. Mark, I bet you've not seen something like this. I hope not. That was my first impression. I said, I don't want this baby, and this is full of complications, especially for the fact that she's been on steroids, and also I dread patients who are on osteoporosis medication come with like this and for a revision, because the quality of bone. Kapil, sir.
Unfortunately, I've been in this situation.
Aha.
But my patient was slightly different. She had a humeral non-union fixed with a vascularized fibrillar graft, which did not take and it broke. So we were faced with a similar degree of bone loss, and exactly same thing, jutting up.
Yeah. Age?
Age 75
Yeah,
or
around
something.
the same,
So poor
yeah.
bone.
Yeah.
And this I did about just before COVID, so 5 years ago.
Yeah.
Patient is still alive, and my solution was to do something like the SRS, but with a Bailey-Walker articulation, because that gives you the constraint. The concerns are the big screw that goes into the glenoid and the osteoporosis and the poor bone, but I've got away with it. But one swallow doesn't make summer, but that is a solution. You accept that function is going to be poor, but you will avoid all this. So my patient has never come back to me follow-up. I've just seen her recent x-rays because she was under the care of the hip surgeons. I was trying to find that on my computer, but I could not find it just now. There's a little bit of lucency around the central big screw in Bailey-Walker, but it is still there. So that is probably a solution, completely off-piste, but that is a solution if you want. But I don't know, you must have some clever tricks, so I'll wait to hear that.
No, my first gut instinct was just to tell her leave her be, but her pain was so incredible. And with that process coming out, my biggest fear was, you can take the ARS off. My worry was if that process was to break through screen, then she is going to land up, and that's going to create a situation which is infection with this is like perfect recipe for disaster. Ram, you want to say something?
Oh, it's a similar situation I had for a post-traumatic with the proximal humeral loss and the hemiarthroplasty under the skin, exactly with the 2 operations, scar, etc. It is possible to do reverse shoulder, but with limited goals.
Yes.
Because I had to do a
this lady
humeral.
is not asking for function. She just
Absolutely.
wants to get rid of pain.
Humeral split osteotomy, bigger, longer stem reverse, glenoid reconstruction, and
But your
rotations will
patient
not be
would
there.
have had some soft tissue cover. Deltoid
Some
would have
soft
been
tissue,
intact, right?
Deltoid partly intact, around 50-60% intact, but she had only function up to 90 degrees, forward flexion, abduction, very little rotation, but the shoulder is stable. So that's something we can consider. In the pre-reverse era, I also like to comment, in the past we have done one case with the oncology team. They used to excise the tumor, they put a nail in the humerus, they tie the top end of the nail to the acromion, leave it just like a flail shoulder, but with no pain. That is also something to consider, like a salvage
Yeah, but
option.
for a sarcoma, I would consider that.
Yes,
not
yes.
for
Not for this
not
one.
for this.
I think for me, I haven't had a case as bad as this, but I would also go for the SRS type of reconstruction, because it looks like she does have at least posterior deltoid and maybe a little bit of the medial deltoid, no anterior deltoid. So I think if you, the one thing with this case is you need to make sure that you know the length of the arm, because if you make her shorter, she's going to dislocate from day one.
Yes.
So I would lateralize as much as possible. So, on the humerus, I'd lateralize, so I'd use that SRS with the lateral, because that's going to lateralize the humerus, and that'll give a little bit of function with the deltoid and maybe wrap it a little bit. But I'd use as much constrained, which I don't like to, so I'd use the, you know, the constrained poly and everything. And then tell her that she's not going to move. It's just so she doesn't have that thing popping out of the skin. But I'd be very nervous because I know, you know.
So we faced, yes, Amit.
Chondrosarcoma, we have done similar kind of a reconstruction. Take a mesh, fix it with to the glenoid all around, and then you suture it all around the head. So it gives us stability, no function, but in chondrosarcoma it works well. We have 2 or 3 cases like that.
So there's no replacement.
No, there's a replacement.
Hemi.
Because chondrosarcoma you have to have a very good wide excision. So it's similar processes, but tumor processes which has a metal but there's no attachment. So we create a capsule first with the anchor all around the glenoid, just like a sleeve, and that sleeve comes all around the processes.
So you're proposing a hemi, not a reverse.
No, not.
Okay.
No, I think you are telling as the first case, first surgery, not now.
First surgery.
First surgery. He's telling what is.
Yeah. So the tissues are all there.
Tissues are, so it doesn't dislocate.
Now it doesn't work.
Yeah. Okay. So my worry, apart from the fact, was that number one, she's had radiation, she's steroids, she's on osteoporosis medication, and incredible once a month. So I stopped that for sure. Number one. Number two, we got her DEXA scans done, but they were representative. They were kind of normalish. So I was freaking out that she might turn out minus 4.5, minus 5 on the DEXA, which was just minus 2.6, minus 2.7. So we thought there's some hope here. And I did consent her for, I said, if I go in and if I find there's just like a, rotten tomato, then I'll just do an excision arthroplasty. And that was my fallback, that the worst case, I'll just remove this and leave it flail, and then you accept whatever it is. Pain should go down here. But I was keen to give her a reverse and some function. So we planned a pec major flap. And this is a pedicle flap. So pedicled on the neurovascular bundle here superiorly, and I'll come to that. And because for number one reason, I needed the flap to give anterior tissue. I don't want my prosthesis sitting under the skin, and that would be very risky. And then sat down and I said, let's plan the pec major flap in such a manner that I will flip it over. You open it like a book, and the superior part, I will disinsert the deltoid and fix this into the lateral clavicle and acromion, and the distal part, I will fix into the deltoid tuberosity. For whatever it is worth in a transverse, if it really functions and if it starts contracting, she'll actually get function in addition to this, and being a neurovascular pedicle is going to fire. So number one option was, of course, it would be a passive transfer and give enough bulk and tissue. So we got this flap done, and just the superior part, flipped it over, got it, and then put it in there. And very gentle rehab. She's just, we did this in December, so she's only just 2.5, 3 months in. And she's pain-free completely. She's better movement than what she has. She's sleeping well. I know that. It's very early days yet. But I have had a similar patient previously that we came out of, and that's why the pec major comes in very useful, where she's had 4 surgeries for greater tuberosity, fracture, went in non-union, osteolysis, and then she came to me 4 years later, was absolutely miserable with complete proximal migration, and the deltoid was completely wasted. So her cuff was also dysfunctional. Not as bad, but similar patient. And that I have a 6-year follow-up on, and she has got a very impressive range of movement. So I thought this would work well. It has to be a good vascular muscle and give me good function. These are stuff that she's never done before. So her ideals are back. She's sleeping better. In retrospect, as Pankaj said, these are 2 other patients that I've had. They came to me first, plasmacytoma extensive. This one is a 73 recently done. He had a fracture of his lateral cortex, but everything maintained. And this another view of that. And I've just nailed him there. That's all you need to do. Just do a prophylactic nailing and just have a dialogue with your oncologist that don't give radiation to this patient and just give chemo, because radiation and steroids and age is a triple whammy. That fracture will not heal and everything will break apart. And you'll be surprised how nicely and fast these tissues will heal up. So in conclusion, this is Basan's paper is the only paper that I know pec major transfer. The pedicled pec major transfer, these guys have published a series of 21 patients, and most of these were post-dislocation, mind you. Their youngest patient was 17 years old, and they've done isolated pedicled pec major for 13 patients. And then in addition, 8 patients had a lat dorsi, oblique, this thing, lower trapezius, in addition to the pedicled pec major. Now, that's being very brave, but very significant results here. But this is what I meant to say was, this is the neurovascular pedicle, and this is the superior branch lateral pectoral nerve. And you just want to flip this over, like in book, so, and ensure that there is no torsion. But you have to disinsert, remove the deltoid from the lateral third clavicle acromion, and disinsert the pec major from distally, and then reinsert it. And look at the range of movements. Pre-op 15 is gone to 83, abduction from 12 to 20. External rotation hasn't been so impressive, between 5 and 30. But look at their SSV scores from 7 to 53%. These are difficult patients, and you would have said that axillary neuropathy is a strict, absolute contraindication to doing reverse, but this is reverse with a pedicled pec major flap. So there is still hope on these. And just finish off with multiple myeloma. You must understand these are several studies. There's almost 10 to 11 year median survival on these patients, so you can't just leave them be. Most of the times they've done nailing. Cemented and uncemented nailing, there's no difference in the outcomes. And the prognosis gets worse when it's a multiple myeloma, metastasis. It's a secretory myeloma, which means you've got Benz-Jones proteins in urine several times over the next follow-ups. But the issues are these. You must insist that they use chemo and not radiation and steroids on these patients. But significant survival rates there. So we don't treat them like a sarcoma or a osteogenic sarcoma as such. Thank you.
Excellent case, Ashish. So you were finally able to bring it down. You know, we had this discussion on the group, and I said, Ashish, you'll be able to bring it down. So you did.
May I ask you a question, Ashish, sir?
Yes.
Yeah.
So have you retained the stem on that lady? Is the same stem?
No. We removed the stem. Yeah, we revised the stem.
But it seems like, is it a custom?
No. I have mismatched. I put the biomet on the top and the evolutus below.
Evolutus below. What's the reasoning, sir?
Actually, we went evolutus and we removed the stem, put in the stem, and then went in to do the glenoid. I found the glenoid very osteoporotic, and I'm very skeptical of the evolutus. What I have removed and revised, the base plate doesn't get osteointegrated, especially in this patient. So as a fallback, we kept that separate. So we've matched the glenosphere to the tray.
Biomet also has a long stem, fracture stem sort of.
Wasn't available that time.
Okay. So you already implanted the stem and then you realized.
The plan was to do a evolutus anyway, long stem evolutus, and we said, I thought if the stem doesn't come out, we'll use the same stem, but that was not going to happen because the balancing was not good. My worry was removing the stem, whether we would fracture that distal pass. If we fracture the distal pass, it's going to be even
My
further
question here, sir, is that did you have a pre-operative understanding that both these mix and matches will work, or?
Oh, we've done that on exceptional cases. When I have a glenoid failure, it's an exception. I don't do that as a choice. I've done the mismatch of because the biomet comprehensive glenoid just sits in there rock solid. So it mixes and matches the striker and arthrex beautifully well. But even this, so you are compelled to use a 36 glenosphere. You can't use a 39 glenosphere.
My question is regards bringing up a discussion of complete proximal humerus loss, either because of tumor or because of the revision fracture scenario. Do you have experience, and what is the way forward wherein you use an allograft of the proximal humerus along with the cuff attachments, and then you try to do some sort of a tendon transfers along with, as Basam has shown, some very complex cases. So what is the way forward for such cases?
So we don't have that kind of composite allograft here. And the only one tip I can give you from Joachim and Basam's cases are that when they get a humeral proximal allograft, they keep the posterior capsule intact. And then Joachim uses the posterior capsule to augment the infraspinatus and ties it down to the LTT. So they don't need an additional graft to the LTT. Otherwise, you've got an allograft with a reverse. So that's like creating a problem. So if you have a procurement of an allograft, then keep the posterior capsule, which is very thick, and you can use that as an extension tied to your lower trapezius transfer. Thank you.
Okay, I think, thank you so very much, Dr. Ashish.